All right, welcome back from break. Our next panel or our next presentation is Saluting Global Immunization Efforts, 154 plus million lives saved. In a major landmark study published by The Lancet, authors revealed that global immunization efforts have saved an estimated 154 million lives, or the equivalent of 6 lives saved every minute of every year over the past 50 years. The vast majority of lives saved, 101 million, were those of infants. With the goal of saving millions of lives more, we'll hear about what is humanly possible, a joint campaign of WHO, UNICEF, Gavi, and the Bill and Melinda Gates Foundation. This communication campaign calls on world leaders to advocate, support, and fund vaccines and the immunization programs that deliver these life-saving products. The NVAC salutes the monumental efforts over the last 5 years to immunize all people across the globe throughout their lifespan. Today, we celebrate one of our greatest public health accomplishments. We will now hear from Soo-Yoon Sim from the World Health Organization. Soo-Yoon, I see you on video and your slides are up. You have the floor.
Thank you very much. Good morning, the members of the National Vaccine Advisory Committee members and the participants. My name is Soo-Yoon Sim. I'm a technical officer from WHO Department of Immunization, Vaccines and Biologicals, IVD. Today, I'm speaking on behalf of Dr. Neil Barzib and his team, who has led this impact modeling analysis to celebrate the 50 years anniversary of expanded program on immunization. Next slide, please. So I'll go over the background of this analysis, but the majority of the presentation will focus on the analysis itself with the scope, method, and results, which will be followed by the questions and answers and discussion with the NVAC members and participants. Next slide. And next slide. Yeah, over the past 50 years, immunization programs around the world have driven towards equity and access as a foundation of the primary healthcare. So as you see in the graph, this is the 50-year trajectory with the historical milestones, as well as the performance in terms of DTP3 coverage rate. So since 1974, when WHO expanded program on immunization was established during the World Health Assembly that year as a request from the member states. In the beginning, there was only about 5% of the world's children were protected from 6 diseases, diphtheria, tetanus, and pertussis, and TB, and measles, and polio. But it actually rose to 86% in 2019 before the COVID-19 pandemic, and now in 2022, around 84%. So along this trajectory towards a remarkable achievement, there was a key moment. For example, Powell's Revolving Fund was established in 1979 to address supply equity and ensure the accessibility and affordability of the vaccine and supplies. And in early 1980s, you see under Jim Grant, UNICEF Child Survival and Development Revolution Initiative initiated a massive scale-up. Also, another key moment was when Gavi, the Vaccine Alliance was established by the efforts from the partners to reduce the equity gap across the countries. And Gavi-supported vaccines, the number of the Gavi-supported vaccine has risen from 6 then to now 19. Starting in 2006, we've seen global strategy developed, starting with Global Immunization Vision and Strategy, GIVS, which was renewed in 2011 as Global Vaccine Action Plan, GVAC, and start in 2021, the global community developed the Immunization Agenda 2030 with a vision of expanding the full benefit of vaccines to everywhere, at every age, to everyone, to every age, to everywhere. Also putting the primary healthcare at the center, recognizing the additional progress required a diagonal approach, building on the PhD system. Next slide, please. So the number of the vaccine preventable disease covered by EPI has also grew from 7 to now 13. And speaking of the 7 BPDs, you remember that WHO launched an intensified plan to eradicate smallpox starting in the late 60s with widespread immunization and surveillance strategies. And then last known natural case was in 1977 in Somalia, and 1980, the smallpox eradication was declared by WHO. And since then, the EPI now covers 13 global BPDs, and also the 17 context-specific regional level vaccine preventable disease that spans across the life course. Next slide, please. And 2024 this year marks the 50 years anniversary of EPI. During the World Immunization Week this year, which happened during the last week of April, this campaign titled Humanly Possible was launched. This is a non-branded white label campaign coordinated by the WHO, UNICEF, and Gavi, and Bill and Melinda Gates Foundation, calling on world leaders to advocate, support, and fund vaccines and immunization programs, reaffirm their commitment to public health while celebrating one of the humanity's greatest achievements. And social media tiles and all the materials and advocacy efforts, you can find more information in the link shared on the slide. So another key element of this campaign was to quantify the impact of immunization efforts in the past 50 years. Next slide. Which was led by our team at WHO IBB. This was a modeling analysis published in the Lancet on May 2nd, 2024, which I'll go more in depth in the next slides. Next slide. Next. So the scope was the historical public impact of vaccination for pathogen within EPI, so 50 years for all 194 WHO member states. And the pathogen scope, we covered 14, 11 from 13 BPDs, except HPV and COVID-19, and 3 from the 17 context-specific BPDs, Japanese encephalitis, Neisseria meningitis A, and yellow fever. We used the framework developed by WHO, first used for IA 2030 analysis. And then to estimate at this, we needed a counterfactual of no historical vaccination since 1974. We looked at the calendar year impact to present a cross-sectional view. We leveraging on the several sources of the models, and here are outcome measures. Death averted, years of life gained, which is death averted multiplied by the life expectancy, and years of full health gain. This is equivalent to disability adjusted life years averted, but this term was used to be in line with the other terminology. And finally, the proportion of the infant mortality reduction attributable to vaccination. And then we also highlight that this is a conservative approach and the robust minimum, because we try to present the complete picture, but inherently there's some limitation based on the availability of the estimates and the model and the data. Next. Yeah, to provide an additional background about the Immunization Agenda 2030. So this specific EPI 50 modeling analysis really builds on the previous efforts that look at the impact of the vaccination for the next 50 years. So what will we achieve by meeting the coverage target for the next decade? So this estimate, you may already be familiar, but we estimated that 15 million future deaths will be averted due to the vaccination activities taking place from 2021 to 2030, which was used used for advocacy when the IA 2030 was launched for the first time in 2021. And annually, we also use the same model to track the progress based on the new coverage estimates against the set targets in the beginning of the decade to be accountable for our performance as part of the monitoring and evaluation framework. Next. And I'll go through the method briefly. So first of all, the data sources, the coverage estimates are mainly sourced from the WHO immunization dashboard, which features the WHO and UNICEF national immunization coverage estimates. And we also have maintained a database for all supplementary immunization activities happening in the country, and polio information system. And finally, which have been complemented by additional estimates from the Vaccine Impact Modeling Consortium. Next. For the models, the golden rule is to use dynamic transmission models when possible, but as is not always the case, that we actually leverage three different sources of the model. First is the dynamic transmission for the measles and polio, for which we have estimates for all member states and all years from 1974 to 2024. And then secondly, a suite of transmission models we received from the Vaccine Impact Modeling Consortium for these 8 diseases. So in many cases, the model estimates were not complete for all 994 countries. In such case, we use temporal extrapolation and geographical imputation to be able to generate the estimates for the missing countries and years. Finally, for diphtheria, tetanus, pertussis, and TB, these are based on the static model, leveraging the global burden of disease mortality estimates, and we actually coupled with additional estimates for the coverage and also efficacy profile for different vaccination activities and for pregnancy schedule, especially for tetanus. We upgraded these models that was first used for the I-2030 analysis. Next. So graphically, we see that for most of the pathogens, dynamic transmission models were used, and geographic imputation and temporal extrapolation were minimal for most of the cases. Next. Even the role was a bit minimal, this was where a lot of our methodological advancements took place. So first of all, is the temporal extrapolation, and we characterized a relationship between the coverage and impact by using the 4 different functional forms. First of all, for example, linear assumption is each dose is equal and the coverage has no effect. Logarithmic and exponential is each additional dose has a lesser or a greater impact. And the sigmoidal is where you usually assume the program takes time to establish, but eventually each doses becomes less impactful. So we fitted this relationship between impact and coverage to different country and different vaccination activity to come up with the most locally relevant relationship between two. And this next slide shows the results of this, and then how different functional form are fitted for especially for this purpose. And next. And for the geographical imputation, we use the time series regression model to impute the results for the country that don't have the modeling estimates by using these are some of the examples of the predictor variables, mostly the socioeconomic and the demographic variables. There are in fact more than 20, but these are some of the examples to show the predictors of the impact and how we imputed this impact estimates for the countries. But in the future, we try to extend this model to also help identify and the gap areas in many different geographies, and also strengthen the vaccine program impact. Next. Yes, finally, the results. So vaccination has averted 154 million deaths since EPI launched in 1974, and measles accounts for 60% of the total benefits. and the single greatest contributor to this. And then 9 billions of lives have been saved, considering that the majority of the deaths averted are children under 5. Finally, the panel C shows 10.2 billion years of the full health gained, which shows the vaccination also prevents the long-term consequences associated with the severe disease. And the green area is the polio, so which accounts for the 8% of the STALIs averted, representing the great morbidity impact as well. Next. And we wanted to show the breakdown of this impact by the WHO region. You see the measles dominating this impact, as you've seen in the graph. And the next, we also broke this down by the income group, and also the measles as the greatest contributor, but also you also see the temporal effect, the inflection point you see during the 1980s when the massive scale up took place. Next. And the second set of the results deal with the vaccine's contribution to the infant mortality reduction. So just to be clear, that infant mortality itself was falling even before the 1974 launch of EPI, and continues to fall. But here, in this figure, we wanted to show you the contribution of the vaccination to this. And in the C is you see the trend of the vaccination coverage increasing over time, and the panel A and B. A is for the infant mortality rate, and the B actually shows the same thing, more in a cumulative infant death space. And the dotted line on the very top is the hypothetical scenario of no improvement in the infant survival since 1974. So it's relatively flat. And the second dotted line is a hypothetical scenario of the no vaccination only. And then the solid line is the vaccination as observed. So blue line really represent the vaccination contribution to this decline in the mortality rate. And this 40% of the reduction is attributable to the vaccination, but 40% is in the aggregate. So actually, when you see this by year, you see this blue area decreases over time. The proportion of the blue area, the total gap, decreases over time, which means that contribution of the non-vaccine factors has increased over time, is becoming more important, also highlighting the importance of primary healthcare and also social determinants of the health in improving the child survival. Next. We broke this, we try to show this in show this by region, and then starting from the absolute decrease in the percentage point of the infant mortality rate on the top to the relative decrease, proportional change in the middle, and finally the contribution of the vaccination to decrease in infant mortality rate that varies across the region. Varies from the 21% in the Western Pacific region to the over 50% in the African region. So you actually really need to put this into context of the region, and especially even in the country level, to understand what factor has contributed most to the mortality rate reduction during this time period. Next. Final set of the result is about the increase in the survival probability. So on the figure, you see is actually the marginal difference between two scenarios. One is the vaccination as scenario where vaccination took place as observed until now. And the second scenario is the hypothetical of scenario of the no vaccination. So actually the y-axis you see is a snapshot. Actually, this is a snapshot of the 2024, but x-axis you see the age groups, and the y-axis is for the panel A is the relative marginal difference, and the B is an absolute marginal difference between in the survival probability between two scenarios. And the plot lines has like regions as well as this world, and you see the black line is for the world. So if you follow that black line, so in 2024, a child at any age under 10 years is at least 40% more likely to survive to their next birthday compared to a hypothetical scenario of no vaccination in the past 50 years. This protective benefits continue past the age of the 50 and globally. And if you look at further into the regional breakdown, is greatest absolute benefits in Eastern Mediterranean and African region, but there are also the greatest relative benefits in the Western Pacific, Americas, and Eastern Mediterranean regions up until the early adulthood. Next. Yeah, just to conclude, that these are the key messages from this analysis. Since 1974, EPI has saved over 154 million lives saved, and majority of them are children under age 5. Measles accounting for 60% of this benefit, and 10.2 billion years of the full health gain. When you divide this by 154 million lives saved, for every life saved, 66 years of the full health regained. Polio has a great significant morbidity impact. And vaccination has accounted for the 40% of the reduction in infant mortality globally since 1974. And any child at age under 10 is 40% more likely to survive to their next birthday, relative to a hypothetical scenario of no historical vaccination. This increased survival probability is also observed even well into the adulthood, even though this specific analysis focused a lot on childhood vaccination. Next. Finally, given that we quantified and observed, and also in person, we firsthand experienced the great impact of EPI and immunization efforts in general. This campaign that was launched this year, which is going to be a year-long effort, really calls for global efforts to intensify this efforts and retain the benefits that came from the last 50 years. So we still envision the world where everyone to benefit from this life-saving power of vaccines, but by doing these following actions, which is ensuring that vaccines are high on the priority list for all governments, and advocating for vaccines to be an integral part of the planning and investment of healthcare access across life course, making sure that immunization programs are adequately financed and resourced in all countries, accelerating research and about innovation that advances access to and support for vaccines. Finally, speaking out on the impact of vaccinations locally, nationally, and globally. So, and the next slide shows the series of the resources that we would like to share, not just the publication itself, but also the open source code library, as well as the frequently asked questions for the study findings. And the next slide, if you have any questions, please don't hesitate to contact us, myself or the Dr. Naura Ziv, and I'll conclude my presentation here to actually to get more questions and then engage in discussion. Thank you.
Thank you very much, Dr. Sim. Nicely presented. I think your messages for the Humanly Possible campaign are absolutely critical for all of us. We can't stop here. We've got to continue to move forward, and on the research aspect, on the access and the funding of vaccines to continue to make those impacts. Are there any other questions or comments from members of the committee here in the room or online? Not seeing any. Thank you very much for your time and your presentation.
Thank you very much for the invitation.
All right, our next presentation is a research review, an eye-opening study on switching arms between COVID-19 vaccine doses. Our presenter is Dr. Marcel Kerlin from the Oregon Health and Sciences University. He'll present findings from a study published in the Journal of Clinical Investigation that found a substantial increase in antibody response to 2-dose vaccinations when the vaccine was administered in each arm instead of both vaccines administered into one arm. Dr. Curlin, you're dispelling all of the myths that I've taught myself. So thank you. Appreciate you being here with us.
Thank you, Dr. Hopkins. It's a pleasure to be here. I'm very grateful to Rebecca and Ann for safely getting me here and coordinating my visit, and I'm very honored to have a chance to present our work at this group. I'd like to first just describe the background and the setting that we did the study in, then move to the experimental data, and finally close with some commentary on possible mechanisms and significance. I'd like to go through the background rather quickly so we have time to think about the data, but if there are questions about that you might have missed later, we can address that. So just briefly, disclosures, I have none. This study was funded by the M.J. Murdoch Charitable Trust, a grant from the OHSU Foundation, and 3 NIH grants. The funders had no role in the design, conduct, or interpretation of our study, and this research was performed after IRB approval and with consent, written consent by the participants. These are a few terms that you might see in this presentation: binding antibodies, an abbreviation for the Pfizer-BioNTech first-generation vaccine. C19 study refers to the OHSU COVID-19 serology study, the umbrella study for this work, healthcare workers, neutralizing antibodies, study participants, and then V1 and W1. These are indicators for which vaccine I'm talking about and which sampling visit. For those of you who don't know, OHSU is a 576-bed teaching hospital. In Portland, Oregon, we have 22,000 employees. We see maybe 1.1 million clinic visits per year and 340,000 admissions. We're really the premier research and academic facility between Seattle and San Francisco. Back in the work that I'm going to discuss today stems from the vaccine drive that occurred in 2020. I think back then we were all became accustomed to watching these rather scary maps of the progression of COVID sweeping across the country and around the world. At the same time, there was hope in late 2020 because we knew these vaccines were arriving. And by December of 2020, OHSU would start vaccinating 1,000 hospital workers each day in our occupational health department. So we were very, very just grateful for that advent. At the same time, everyone was recognizing that there were deep gaps in our fundamental understanding of COVID and the response to vaccines and what it would mean, for example, to get COVID infection and then vaccination and vice versa. Many, many scientific questions that remained unanswered. This photo is the first person who got a COVID vaccine at OHSU, groundbreaking. And while this was happening, we decided to start a cohort study to study immune responses. We performed data collection, demographics, and vaccination history and infection history. We also performed blood collection and vaccination. And in total, within the C19 study, we recruited 2,016 participants. This is a schematic that shows the places that study in context. At the bottom, what you see is the incidence curve of COVID in the state of Oregon from early 2020 until February of 2022. And so you can see the rise and fall of the different epidemic waves. In the middle is a schematic representing the vaccine rollout effort at OHSU. And then finally, across the top are the sampling times in the COVID-19 study. What I'd like to turn to, we did see we got a lot of interesting observations from this overall study, but what I want to focus on is arm randomization. As Dr. Hopkins pointed out, the general assumption usually is that it doesn't matter which arm you get your vaccine in. We go to the physician's office, they just ask you, which arm do you want? And usually I say, well, I'm right-handed, so I might as well get in the left so I can use my right hand without having any pain. It turns out, however, that antigen presentation to the lymph node is a regional process. So if you'd exposed here, the most proximal regional lymph nodes are the ones that are activated. And so there's a theoretical basis that this might actually matter. The other thing is that there are a few studies in animals suggesting that there might be some immunologic effects to varying location of vaccine. The picture I'm showing you is refers to the concept of immunodominance. If I vaccinate a mouse with A on the left, and then I later vaccinate the mouse with A plus B, whatever that might be, often what will happen is the mouse will preferentially respond to A. But by varying the location of that second dose, you can actually get responses to B. So you can break immunodominance by moving the site of vaccination. That's just one hint. There were other little bits of evidence that made us think about this concept. And so we decided to study it. What we did was we took the entire cohort, and after vaccination 1, we randomized all of them by computer by a list to either an ipsilateral or contralateral group, same arm or opposite arm for the second dose. And then when they came in for dose 2, we invited them to participate in the sub-study. We followed them longitudinally. And then what we did was we analyzed 3 groups. One was all participants in the whole cohort who had any data to contribute. The second was those who agreed to randomization. And then the third was a select subset of those randomized who were matched on important demographic variables such as age, time intervals between vaccines, gender, et cetera. And the right-hand side shows a simplified schematic. It's worth taking a quick look there just because we'll see some of these symbols later. There's a baseline sample, which is not shown. Then there's vaccine dose 1, followed by a randomization event, followed by a vaccine dose 2. And then you see wave 2 collection, a wave 3 collection. Some people got a booster dose at visit 3, and then a final late blood collection about 1.1 years after the randomization, wave 4. The assays we performed were the LUMIT assay, which is by Promega. It's an interesting assay that measures SARS-CoV-2 specific total IG, a traditional ELISA, which measures IgG, and then neutralizing antibody assay specific for SARS-CoV-2. This is a brief outline of the group accrual. You see 2016 who entered the study, and then ultimately 947 were randomized, and then you see 108 in that matched pair group. And there are various exclusions why different people did not fall into these groups. Now we're getting into the data part of this, and this is just a brief snapshot of the demographics and what the results were of the overall cohort. Green is women and orange is men, and you see that over time, the women are consistently contributing more to these studies than the male participants. And there's, and that percentage maintains more or less steady over time with each wave. The right-hand plots just show the age distribution at each wave, wave 2, wave 3, and wave 4, showing a broad range from around 18 to about 80 years old. Now we're into the immunologic data. These plots show the antibody response on a log scale on the y-axis. The left-hand panel is IG, total IG by Lumit. The right-hand side is IgG by ELISA. Across the x-axis, they're the different groups. Warm colors represent the opposite arm group, and the cool colors, blues, represent the same arm group. And then within each panel, we're walking from wave 2 to wave 3 to wave 4. So if you look at one panel, the left-hand side is the very earliest sampling, and then over time, we go forward into later times. Don't worry too much about the absolute difference in groups, because I'll show you a table at the end that gives that. It's a little bit hard to see in these plots, but I'll give you a table at the end where we can discuss the absolute differences. So what we're seeing here is in the randomized group. We're looking at antibody results in that 947 who are randomized. And what we're seeing is that consistently over wave 3 and wave 4 particularly, the opposite arm group has consistently both in IG and in IgG a higher SARS-CoV-2 specific antibody response. And the effect seems to grow over time. That's actually a bit unusual. We'll talk about that. Here we're looking at the matched pair group. Same idea, same assays, but in that 108 matched pair group. And what we're seeing is slight differences at W2, at wave 2, immediately after vaccination, but then at W3 and wave 4, this larger difference, particularly for IgG. And now what I'm showing you is the same, but for the neutralizing antibody response. So again, wave 2, modest difference, if any, but then in wave 3 and wave 4, a substantial difference. And what I'll point out is that that effect is quite significant in that latest time point, particularly for the neutralizing antibody response. One other thing to point out, when we did the neutralizing antibody response, we used the original virus, but we also measured antibody responses against the Omicron variant, which these participants had not seen. The randomization happened in early 21. Omicron came a year later. So the randomization happened a year after Omicron. And what we're measuring in the right-hand plot is the neutralizing antibody response to Omicron, not to wave 1. So very significantly, that difference is quite large. We'll talk about that. Here we have what you can also ask is whether the quality of these antibodies is significant. So what we're measuring is the ratio of neutralization to total antibody. If that ratio is high, a lot of your antibodies are contributing to virus neutralization. And if it's low, we would have the opposite. And what we see is that by that measure as well, the opposite arm groups seem to have a better quality of the antibody response. The total antibodies that are present, there's more neutralizing impact of those antibodies. This plot is trying to get some sense of when the effect sets in. What we're looking at is wave 2 data only. It is that first time point after randomization. Because it's an observational study, not everyone came at the same time after dose 2. Some people came quite early and some people came quite late. And that's depicted on the x-axis of this plot. What we're seeing is that in the orange data, the orange lines show a curve fitting to the results for the opposite arm group, and the blue is for the same arm group. And what we're seeing is that at very early times after vaccination 2, there's not much difference between groups, but that at times later, those graphs start to separate. And so the implication is that the added benefit that you get from switching arms occurs at times a bit later than immediately after vaccination. And then finally, what you could ask is, well, some people got 3 doses. Is it important to switch arms in that 3rd dose? How does that all work? There are 4 different possible combinations that you can have. On the left, you see the boost happening, the 2nd dose happening in the same arm, followed by a 3rd in the same arm. That's one way that you could do it. Or you could say same to opposite, right? So the first 2 doses in the same arm and the 3rd one in the opposite. Or you could alternate, you could say opposite same, so you switch between dose 1 and dose 2 and then go back to, and then stay with that 2nd arm, or you could switch each time. Okay, so I've grouped them into 2, and what we're seeing in these data are that it is the first 2 doses where the switch is important. The 3rd dose is essentially irrelevant. If you switch between dose 1 and dose 2, the initial exposure, that is where you're getting your benefit. This is, I promised you, a table of the absolute changes that we see. There are p-values on the right, and then the second column over shows the fold change, the absolute fold change in antibody responses. There are a lot of data here, but what I want to just do is focus on these last 4 rows. This is wave 4, and the first 2 rows are a homologous neutralizing antibody challenge, and the second 2 rows are the heterologous challenge. So it's to Omicron. And this is wave 4, the neutralizing antibody response. What we're saying is that the neutralizing antibody response to late heterologous challenge to a different virus is where we're getting the greatest impact. And I would say that is the most important thing, actually. When we vaccinate people, we're not necessarily worried about what happens in the next week or 10 days. It's how durable are those immune responses, and how well will they be able to cope with a challenge from a virus that has changed a little bit over time. And so this is where we're seeing a between 3.5 to 4-fold increase in antibody titers. This work was done by a tremendous number of people. I would like to just call out the Occupational Health Department at OHSU, as well as numerous labs, Bill Messer's lab from OHSU, the Oregon Clinical and Translational Research Institute bioinformatics team, and the Oak Tree generally, David Montefiore at Duke, who did the neutralizing antibody assays, Mark Slifka, who did the ELISAs, an army of medical students who helped us recruit 2,000 people, and then 2 talented trainees, and finally the many study participants who joined. Those are the data. I'd like to just share a few thoughts and speculation, and I'd be honored for any thoughts that you might have or questions in helping us think through these data. Why is this happening? Well, I said before that antibody presentation is regional, and I think what's happening when you switch location between dose 1 and dose 2 is you're allowing a primary immunologic response in 2 different lymph node systems, as opposed to recalling a secondary response in the same lymph node. Ultimately, what I think is that leads to a larger pool of memory B cells that are available to respond. And since each memory B cell is unique, that implies a larger number of cells and also a broader repertoire to respond from. That's my general thought about this. I think it's a bit early to make any recommendations. Should we all be switching arms? I chose to switch mine between dose 1 and dose 2, actually, but I think it is early for recommendations. The study is quite solid in the sense that we have a large cohort. We analyzed it in several different ways using all individuals. We have the weight of numbers. We looked at it in a randomized fashion, and we looked at it in matched, a very sort of high quality matching system. And no matter how you slice it, age, gender, it doesn't matter. The result is the same. And so the effect is really there. On the other hand, we only looked at one vaccine platform. It's only in adults. And we did not look at cellular immunity. So there are many questions still to ask. I think we need studies there, but I don't see a downside to switching arms at this point. I would say that. My last real comments here are about significance. Firstly, a 4-fold increase could affect a number of people. I was very inspired by the last talk where we were talking about the large number of people around the world that have been saved by vaccines. Imagine a 4-fold increase in antibody titers multiplied over the number of people who have gotten vaccinated. That would be significant in and of itself. I also call to mind the experience we had with RV144, the HIV vaccine trial. Of course, HIV vaccines are really one of the hardest biomedical challenges we've faced. And the only study to show any efficacy at all was RV144. Unfortunately, that study did not, they had a 30% efficacy at 6 months, which was not sufficient for us to go forward. But we know that antibody titers, particularly to a heterologous late challenge, would be great correlates of protection. So what would happen if we had loaded on the benefit of arm switching onto that study or any future study that is near the edge of significance? Edge effects around people who are near the threshold for severe illness. A young, healthy 20-year-old may not benefit from a 4-fold increase, but someone who's 65 and is destined to get COVID, maybe that benefit would be sufficient to save them from a bad outcome. And then the last point I would make is we know that other things may impact vaccine responses, not just arm selection, but a number of other factors. And if they could be placed on the same footing as arm selection in terms of our evidence, the question would be, are those then additive, competitive, or could they even be synergistic? If we're getting a 4-fold increase now, Could we bump that to 6 or 8-fold, or could we get a log? Can we improve vaccination by vaccinating smarter rather than just harder with more doses and adjuvants? So those are the questions I think it's worthy of study. Those are the end of my comments, but I'd love any questions you might have. Thank you.
Well, thank you, Dr. Curlin. You've raised a number of important questions, and certainly, at least in my mind, dispel at least one myth that we try not to propagate myths, but I think we all tend to do that. The other piece that I might add a comment to at least think about is, would there be a differential effect depending on adjuvant? Not just vaccine platform, but would an adjuvant administration be potentially more beneficial, giving it a different site than the site that you're giving the vaccine? So something else to throw into your mix of future questions. Are there any other questions or comments from members of the committee, either here in the room or online? We're all trying to remember which arm we got our COVID vaccines in. I think that's.
I did the same.
Well, thank you very much. You've certainly given us something to chew on. Thank you for joining us today and for your presentation. We've now reached the time for our liaison member and federal agency updates. We're going to start with our liaison members. Our first liaison presentation from AIM is Claire Hannon. Not going to give you a chance to get your notes out.
Good afternoon. Thanks, Dr. Hopkins. It's good to be here. I'm with the Association of Immunization Managers, and we did submit a written report, but I will highlight a few things. We are in the midst of holding 8 regional vaccine access cooperative meetings where we are bringing together immunization program staff from each jurisdiction with partners from their jurisdiction. So a representative of pharmacy or family physicians or FQHCs or Medicaid or Medicare, relevant partners to improving adult immunization coverage rates. And so it's been very exciting to have jurisdictions meet regionally to learn from other jurisdictions in their region, and then also to develop a specific team of partnerships to sit at a table in person, to identify challenges and to identify steps to work with those challenges. It's a particularly tough sort of environment right now for adult immunization, coming off the pandemic, having made so much improvements that, like Rebecca talked about, with data collection and sharing, having providers enrolled to give COVID vaccine, having staff to support that, all of those sort of emergency pandemic COVID infrastructure pieces coming into place, but now perhaps not being able to be supported by routine funding moving forward. So it's a difficult environment, but we're very excited to have these meetings. They've been very successful. We've held 3, we have 5 more to go. We are also in the midst of implementing our Immunization Champion Award in cooperation with CDC. This is a chance for each jurisdiction to identify an immunization champion in their jurisdiction who is someone that promotes vaccination and does work to get more people vaccinated. And we provide the award and give them an opportunity to have a celebration of success in their jurisdiction. So that's going on right now. Those will be awarded in August. We're going through the nomination process right now. We also, the other thing I wanted to highlight is that we've been working with CDC to conduct 2 surveys. One of them is an assessment, a needs assessment of programs for their adult immunization activities. And the other is around measles and what they are potentially, what data they're collecting and potentially have to identify regions or areas or zip codes or populations that might be more prone or there might be an outbreak potential there. So trying to identify those and trying to take steps to work in those communities to improve vaccination. So I will stop there. There's more in my written report, but thanks for the opportunity and thanks so much for making me go first.
Happy to do it, Claire. Next for ARA, Rebecca Coyle.
Thank you, and I appreciate y'all giving us time to give an update. So last month, we were in Orlando, Florida for our national meeting. We had over 587 attendees representing 55 jurisdictions in 5 countries, where everybody got to hear all the latest and greatest about immunization efforts, a lot of the work that's being done out there. So really a unique opportunity to hear a lot about IIS. One of the new projects, or I shouldn't say new projects, but one of the results of a new project was creating some interoperability guidance between post-acute and long-term care electronic health record systems. This is a project we've been undertaking for the last year, and I'm pleased to say that it is now available on our website. And the guidance is really targeting the technology vendors and also IIS for how to onboard these systems a little more easily. So very excited to have that out. I'll also just say that we have several new groups that are out there that are really supporting data analysts, the collection of data, how to synthesize that, and then also how to display that. Several of those work groups are available. You can find more information on our website. And then I already mentioned this in my presentation, but I'll just note that for the first time, we did get 100% participation in our measurement and improvement initiative. This is really exciting to show, and that we had over 55 different jurisdictions that were able to achieve validation in some component over the last quarter. So very exciting results to report. Thank you so much for the opportunity to give this update.
Thank you, Rebecca. Next for APHA, Mitch Rotholz.
Thank you. I appreciate having the opportunity to provide an update. We gave a written report. I'll just give some highlights of what's in the report. As Claire mentioned, we are continuing to do collaboration among the immunization neighborhood members and are participating with AIM in their VAC program and other initiatives that are there. And thank you for the collaboration there. Second, we just got done presenting the APHA 2024 Immunization Champion Awards, and the information about those award winners who are making a difference in their communities is on the website for more information. You can go there to get that information. Next, we continue to work on statement of the authority that pharmacists obtain, pharmacy teams obtained during the pandemic through the PrEP Act amendments, and trying to make those become sustained at the state level. So that's taking a lot of effort and collaboration among the pharmacy partners and other partners at the jurisdictions. Next, APHA has been conducting 8 regional and other immunization virtual focus groups to gain insight into current environment, upcoming respiratory season, and how providers are interpreting and utilizing the current recommendations, and where there needs to be a further clarification and support to help providers implement those recommendations. Gain some great insights into those, and a report will be coming out on that as well. And then lastly, we are working across the profession on the engagement of pharmacy within the VFC and barriers and challenges to be addressed to increase engagement. And there's a report that will be coming out that's been facilitated from our National Association for State Pharmacy Associations that has been working across the profession to develop that, as well as we are continuing to monitor the VFC provider numbers within pharmacy, and the challenges continue. And we've got several areas that have been identified where issues need to be addressed to increase provider engagement. Thank you for allowing me to give this report.
Thank you, Mitch. Next for ASTO, Erica McGowan.
Hi, everyone. Thank you. I'm bringing greetings on behalf of our Vice President for Health Security, Meredith Allen, who couldn't be here today. So a few things that we've been doing recently, we continue to do our situational awareness and technical assistance that we provide to all our state and territorial health departments and health officials. And through that, we've been developing a few resources. So we developed a couple short podcasts on measles outbreak, the COVID vaccine, but also a toolkit on the recent measles outbreaks as well. We have conducted a vaccine policy academy. This policy academy was a continuation of an activity that we did in the previous project year. But this year, we really decided to focus on some legislative trends related to vaccine policy and also on implementation of nirsemivab and vaccine-like products. Some of our states were having some trouble with some policy that were barriers there. The lessons learned included the benefits of early engagement, evidence-based advocacy, and transparent communication among stakeholders. The last thing I wanted to mention is a project that we've been engaged in for a few years, supported by CDC. It's a partner locally tailored equity program, or we call it the PAVE program. ASTO worked with National Community Action Partnership and 5 community action agencies, and also a network of partners to use some locally tailored evidence-based strategies to increase vaccine acceptance and uptake amongst racial and ethnic minority populations. This is one of those projects that really allowed us to work closely with community-based organizations and the populations that they serve. So recently we published our culminating toolkit with lessons learned from this project, and also a blog post titled Helping Agencies and Providers Advance Vaccine Equity. We really appreciate this partnership and the partnerships that we have with CDC as well. These projects, this PAVE project in particularly, is going to be ending soon. So it was very useful. We had very great outcomes from that, but we're going to be losing some of that capacity there. So we're just continuing to try to maintain our capacity with our state and territory health officials and all of our partners as we move forward. So I think that's it for me.
Thank you, Erica. Next for NACHO, Judy Schley.
Hi there, my name is Judy Schley. This has been my first NVAC meeting, representing as a liaison for NACHO, and it's been really an honor to participate and learn so much from this meeting. As you know, NACHO represents 3,300 local public health departments and throughout the country. And the thing I wanted to highlight first, and it's part of our written report, is NACHO last week just released its 2023 immunization profile study. And this is a comparison of what was done in 2017 to 2023. And a few things to highlight was the immunization workforce capacity, where about half of the local public health departments reported limited staffing as a key challenge in conducting their immunization-related services, despite the recent growth in overall workforce driven by the COVID-related funding. Vaccine hesitancy is a huge problem that has been identified by our local public health departments as a barrier to getting people vaccinated, and that represented a 46% increase since 2017. The priorities for local public health right now are really trying to bolster confidence for youth and early childhood vaccines, as well as conducting education with community partners. In terms of COVID-19, public health was very instrumental in providing COVID vaccination, and they spent a lot of money on trying to do that and increase accessibility to under-resourced areas. In 2022, 93% of the 93% of the health departments provided COVID-19 to adults, and 87% provided them to children and youth. And they spent 15% of their time focusing on this, thinking about what all the other duties of a local public health department. That's a big shift. And they did a lot of things like increasing walk-in, flexible timing, going out into community, working with community partners to deal with and enhance vaccine accessibility, as well as with health systems. A webinar on this report will come out next week on June the 18th, 12 o'clock Eastern Time, and it is part of our written report. One other thing to highlight is NACCHO will have its annual meeting July the 23rd to the 26th in Detroit, Michigan, and its focus is heard it through the grapevine, public health partnerships, collaboration, and innovation. And there is both open registration for in-person and virtual participation. And that's it. And thank you very much for letting me speak today.
Thank you, Judy. Next, for the Public Health Agency of Canada, Erin Henry.
Great, thanks everyone. Like others, we have a more detailed written report if you would like to refer to that, but just for a few highlights. Even though that we're just come out of a very extensive pandemic, we're very busy planning for our next pandemic. And we are actively monitoring both human and animal outbreaks of avian influenza. At this time, though, the risk to Canadians remains low, and there have been no cases of H5N1 detected in humans or dairy cows, which we are watching very closely what's happening in the US. As part of our pandemic preparedness, Canada does, though, have pandemic influenza vaccine agreements. We have one domestic and two international in the case that we ever do need to call upon having pandemic flu created. As for measles, we've had a very busy year to date in 2024. We've had 77 measles cases reported. That compares to 12 that we had last year. So we're definitely seeing a rise in measles, and to help prevent importations of measles and the risk of spread in Canada, we've taken a number of actions, including sending communications to clinicians to alert them of the symptoms of measles, as we spoke about yesterday. Some of our younger healthcare providers do not recognize, and we've had certain cases that have visited 3 different institutions before they're actually diagnosed. So doing a lot of outreach with our health partners. We're also busy renewing our national immunization strategy, which hasn't been renewed since 2016. We were just starting to do that work when the pandemic started. And so this strategy provides a framework for cross-jurisdictional collaboration to improve relevance, effectiveness, and efficiency of our immunization programs across the country. We held a summit last month with which we brought together a broad range of key immunization partners, along with their provinces and territories, with the goal of reaching a shared understanding of renewed priorities and objectives for 2025 to 2030. So the next steps there include analyzing the data and the feedback that we received at the summit, and we will be crafting our first draft of the strategy with publication planned for late spring 2025. And that's it for today.
Thank you very much, Erin. Now to turn to our ex officio updates. We'll start with ASPR, Kim Armstrong.
Yes. Happy to give the update today. And yes, we have a more detailed written report. But just to remind everybody, I represent the Biomedical Advanced Research and Development Authority, which is BARDA. And BARDA is the premier advanced research and development organization within the US government. And it supports the advanced development, manufacturing, FDA approval, and acquisition of medical countermeasures against chemical, biological, radiological, and nuclear CBRN threats, pandemic influenza, COVID-19, and other emerging infectious diseases. So we have a number of ongoing programs, and I'm just highlighting some of the newer, the newer updates. So on the Sudan Ebola virus vaccine development front, BARDA is supporting IAVI for the development of a VSV vectored Sudan vaccine. Enrollment has completed in a phase 1 clinical trial, which is exciting. On the Marburg virus vaccine front, we are supporting the Sabin Vaccine Institute for development of a chimp-ad3 vectored Marburg vaccine. A phase 2 clinical trial is underway. And we're also supporting the public health vaccines for VSV Marburg vaccine. For this vaccine, enrollment is just completed on a phase 1 clinical trial earlier this year. BARDA is also supporting IAVI for the development of a second VSV vectored Marburg vaccine that is currently in preclinical development, but on target for a phase 1 study to start in early 2025. On the smallpox vaccine front, the vaccine continues to be made available to jurisdictions for the ongoing Mpox response, and this is expected to continue through August 2024. And Bavarian Nordic is now making the vaccine available commercially. The SNS, or the Strategic National Stockpile, will continue to make the Jynneos vaccine available for uninsured and underinsured individuals in the United States. On the pandemic influenza front, I know my colleague, Dr. Christine Oshansky, gave a really great update yesterday, so I don't want to go too much into what she talked about other than to reiterate that the National Pre-Pandemic Influenza Vaccine Stockpile, or MFIMS, is developing and testing vaccines that are closely matched to the current circulating strain that is circulating in both dairy cows and birds in the United States. In addition, on the influenza front, BARDA has partnered with Arcturus Therapeutics, and they have launched a partnership to develop a self-amplifying messenger RNA vaccine against pandemic influenza. Development and preclinical work is continuing and in preparation for a phase 1 clinical trial that should start in early 2025. And then under Project NextGen, BARDA, in partnership with Luminary Labs, will launch 2 prize competitions that will provide prize-based awards to partners that will, 1, focus on the formulation of RNA-based vaccines on microneedle patches, and 2, accelerate the development of a single-dose vaccine that can support rapid pandemic influenza response. The Patch Forward Prize was launched in April 2024 and hosted its first public information session in April, which had strong attendance of over 100 attendees. The proposals for phase 1 are due in October 2024, and the second prize challenge is anticipated to be announced in early 2025. And that concludes my updates.
Thank you very much, Kim. Next for CDC, Captain Mo Patel.
Hi there, can you see me?
I see you. You're loud.
Okay, great. Thank you so much. So like everybody else, appreciate the opportunity to connect with all of you over the course of this meeting. I think that I have 3 comments. Most of our sort of detailed responses are in the submission that we provided to you, but I did want to mention 3 things. One is I heard from this meeting just how critical the partnerships that CDC has with many of you, the presenters and the panelists. Again, that sort of collaboration as we think about protecting health in the US and abroad is really critical for our agency. And we just really appreciate and thank you with much gratitude for all of the collaborators that we have within the federal agencies and outside of that. So I just wanted to first say that. The second point that I want to make is that, again, the importance of vaccinating adults. The Bridge Access Program, as you heard, has provided 1.5 million doses from September of 2023 through May of 2024. And that program is going to be ending in August. And so CDC's one of our priorities is the Vaccines for Adults program. And again, we look to many of you to help support that initiative to help improve vaccination coverage among the more than 25 million uninsured or underinsured adults. And then the last point I just want to make is we look forward to ACIP next week, as I'm sure many of you, to help how we can sort of increase vaccine coverage across all our vaccines, but also the fall-winter seasonal vaccines. And I found this particular statistic really interesting to me. And it's an important role, I think, for you all in terms of implementing these recommendations with us. And that is with nirsevimab. Now, generally, we expect about 10% coverage when a new vaccine comes to from licensure into recommendations. And for nirsevimab, we reached 40%. And this was in light of a shortage. And why I find this so for me, very extraordinary, I'm a pediatrician, is that pediatricians really understand the importance of protecting babies against RSV, and we're very excited about nirsevimab. So the last point just to make here with you all is the importance of really leveraging and including our healthcare provider community, both in the private sector and the public sector, to help increase coverage and protect Americans here and abroad. So thank you very much for the opportunity to say a couple of words.
Thank you. Next for DOD, Lieutenant Colonel Nicole Sue.
Thank you. Can you hear me?
You're loud and clear. You have the floor.
Great. Thank you. This is my first meeting. I am the Deputy Chief for the Immunization Healthcare Division at the Defense Health Agency. So really happy to be here and learn so much over the last 2 days. I'm going to give a couple brief comments about the DoD's programs. One is the Uniformed Services University of the Health Sciences Department of Pediatrics has been supporting a vaccine candidate analysis in small animal models for SARS-CoV-2, influenza, and RSV. This ongoing work includes evaluation of vaccine antigens for RSV and influenza, research on innate immune activation with adjuvants, and routine immunizations, or route of immunization is going to be explored as well. And then two updates on kind of our programs. One is that the Defense Innovation Unit and the Joint Project Manager for Chemical, Biological, Radiological, and Nuclear Medicine are in their second year of collaboration on the Vaccine Acceleration by Modular Progression, or VAMP program. And this program is a vaccine development platform that facilitates rapid delivery of safe and effective vaccines with proven manufacturability, safety, and efficacy in suitable non-clinical models, and safety in clinical human trials to deliver both traditional and nucleic acid-based vaccine candidates against new and emerging threats to enhance overall preparedness. And then final update is that in October of 2023, the Undersecretary of Defense for Personnel and Readiness published the memorandum use of next generation smallpox vaccine, notifying the intent to transition from ACAM 2000 to JYNNEOS as the main smallpox prevent prophylaxis for the DoD. So the Defense Health Agency is actively collaborating with Health Affairs and the services to prepare for the relaunch of the smallpox vaccine program with JYNNEOS. And that's it from our updates. Thank you.
Thank you very much. Our next update is from HRSA, Brenda Holbrook.
Hello, I'm Brenda. My name is, I'm Lieutenant Commander Holbrook, and I'll be providing an update for Health Systems Bureau, Health Resources and Service Administration, or HRSA. A written report has also been submitted. So HRSA continues to play an essential role supporting the nation's public health through administration of two keystone programs, the National Vaccine Injury Program, or VICP, and the Countermeasures Injury Compensation Program, or CICP. So as we all know, vaccines save lives and prevent disease. The VICP, which is a no-fault alternative to the traditional tort system for resolving vaccine injury petitions, was created in the 1980s after lawsuits against the vaccine companies and healthcare providers threatened vaccine shortages and reduced U.S. vaccination rates. So in fiscal year 2024, as of May 1st of this year, petitioners filed 697 vaccine injury compensation program claims, and over 111 million was awarded to those petitioners, and over 30 million was awarded to pay the attorney's fees and costs. There were 610 claims are awaiting activation for review. The CICP, which is an essential response element to the National Emergency Preparedness and Response Network, was created under the Public Readiness and Preparedness Act, or the PrEP Act of 2005. The CICP plays a critical role providing injury compensation for countermeasures deployed in a response to a pandemic, epidemic, or a security threat, including such threats as the COVID-19, Mpox, and the pandemic influenza. So as of May 1st of 2024, There were 13,147 claims alleging injuries and or deaths from COVID-19 countermeasures have been filed with the CICP, and the CICP continues to make tremendous strides in processing these claims, having rendered 2,645 COVID-19 decisions to date. So that's a lot. HRSA welcomes discussion around how the essential roles of the VICP and the CICP can support the upcoming national strategy in 2026. Next, I'll provide an update for HRSA's Bureau of Primary Health Care. A report has also been submitted for this. HRSA's Community Health Center program is a cornerstone of our country's healthcare system, providing affordable, high quality, and comprehensive primary care services to more than 30 million medically underserved people nationwide, especially for individuals and families who are uninsured, enrolled in Medicaid, living in rural, remote, or underserved areas, struggling to afford their health insurance copays, experiencing homelessness, residing in public housing, or otherwise finding it hard to find a doctor or pay for the cost of care. Today, the approximately 1,400 HRSA-funded healthcare centers operate nearly 15,000 healthcare sites, as well as mobile clinics, community outreach events to engage patients in accessible settings, and other satellite sites. So overall, the vaccine administration that was done with these clinics as of April 2024 was over 24,349,000 COVID-19 vaccine doses were administered by all healthcare centers since January 2021. 70% of those were to racial and or ethnic minority patients. So thank you for the opportunity of providing this brief updates, and if there's written reports submitted as well. Thank you for your attention.
Thank you very much. Next, for Indian Health Service, Uzo Chukwuma.
Good afternoon. Can you hear me?
Yes, we can. Please proceed.
Right, thank you for the opportunity to present the Indian Health Service update to this committee. My name is Uzo Chukwuma. I am the Infectious Disease Branch Chief within the Office of Public Health Support and the IHS National Immunization Program Manager. We also submitted a reading report, but would like to share some highlights with you. The Indian Health Service continues to prioritize vaccination as our clinical public health prevention priority and continues to promote efforts to improve vaccination in the American Indian and Alaska Native population. Our national efforts include the IHS E3 vaccine strategy, which ensures that every patient at every encounter is offered every recommended vaccine when appropriate, including all ACIP recommended vaccines in all age groups. Following the announcement of the IHS strategic initiative in 2022, we established the E3 Vaccine Champion Pilot Program in March of 2023. And since then, the IHS has designated over 28 vaccine champion pilot sites in 9 IHS areas, including federal, tribal, and urban programs, and have shared clinical and community resources, as well as multidisciplinary best practices to cross-pollinate our IHS system of care and improve vaccine coverage rates in tribal communities. We have collected and shared best practices and lessons learned from dozens of the E3 champion pilot sites, and some best practices include things around information technology, community engagement, clinic nursing, and pharmacy. For example, the identification of vaccine ambassadors to implement vaccine clinics in the community, remote locations and villages, expansion access and use of the state immunization information system for patient screening. As part of the proactive strategy of outreach, education, and engagement with our partners in the tribal communities, the IHS 2024-25 respiratory viral vaccine campaign is working to ensure timely access to immunizations for COVID, seasonal influenza, and RSV among our vulnerable service population across the age spectrum. Additionally, the IHS Office of Information Technology, in collaboration with the immunization program, in advance of the vaccines being available, is working rapidly to establish the informatics infrastructure, such as CPX codes, the ICE forecaster update, that would support the expedited implementation of the ACIP recommendation in Indian country. Following the reported supply chain constraints in the fall of 2023, IHS worked diligently to secure a supplemental supply of the long-acting monoclonal antibody nasivimab to ensure that this life-saving immunization was available to AIAN infants and children up to 19 months of age. To date, nearly 8,000 supplemental doses of nasivimab have been distributed and administered to mitigate the risk of serious RSV disease among infants and children in Indian country. Due to persistently elevated rates of respiratory virus illness in Indian country, in collaboration with the IHS obstetrics and pediatrics subject matter experts, our chief medical officer extended the period of administration of maternal RSV vaccines to eligible pregnant American Indian and Alaska Native persons through the end of February for the 2023-24 season to mitigate the risk of RSV in a high-risk service population. In preparation for the upcoming second RSV season with availability of long-acting monoclonal antibody countermeasures, the IHS is collaborating with other federal agencies such as CDC and the Administration for Children and Family on an initiative to protect the public against viral respiratory disease by reducing RSV in AIAN infants. The IHS is participating with these agencies in listening sessions in tribal communities to inform immunization communication toolkits and technical assistance to vaccine champions, providers, and families. We look forward to continued collaboration with our tribal, urban, and federal partners to ensure access to safe and effective vaccines across the age spectrum for AIAN Native people served by the Indian Health Service. This concludes my update. Thank you.
Thank you very much. Next, for National Institutes of Health, Andrew Ford.
Good morning, and thank you for the opportunity to provide an update to the committee. At this time, I would like to highlight a few items, two of which are included in NIH's written report. First, to support a robust HHS response to the H5N1 outbreak that has been mentioned by others over the last couple of days, the National Institute of Allergy and Infectious Diseases, or NIAID, continues to leverage its domestic and international infrastructure dedicated to advancing basic and translational research on the H5N1 virus.
I think you have frozen.
Factors that influence the virus's ability to transmit and cause disease, developing and evaluating prevention strategies, advancing existing and novel treatments, and supporting strategies for detecting H5N1 virus. The research agenda aligns with the NIAID role in the federal public health response to the outbreak of H5N1 influenza in people, dairy cows, and other animals. Moving to HIV, research sponsored by NIAID, co-funded by the Bill and Melinda Gates Foundation, and conducted by the Duke Consortium for HIV/AIDS Vaccine Development, in collaboration with the NIAID-funded HIV Vaccine Trials Network, provided proof of concept that a vaccine can induce HIV broadly neutralizing antibodies. This early-stage clinical trial examined the ability of a vaccine concept to elicit broadly neutralizing antibodies that bind to the membrane proximal external region, or MPER, of an HIV surface protein. The study enrolled 24 participants, of whom 20 were randomly selected to receive vaccine doses. Of those 20, 15 received 2 doses and 5 received 3 doses. The investigators found that 13 vaccine recipients generated early-stage MPER-directed antibodies after 2 doses. Among the 5 participants who received 3 doses, the antibodies and samples from 2 of them could neutralize many commonly globally circulating HIV strains in vitro. Moreover, the broadly neutralizing antibodies were detected within weeks, which is much faster than the antibody response in people with HIV. These findings were published in the journal Cell. And then lastly, NIAID with the Bill and Melinda Gates Foundation and the World Health Organization co-host the Global Vaccine and Immunization Research Forum, or GVIRF. The GVIRF is the central forum for research related to Immunization Agenda 2030 and brings together the entire vaccine and immunization research community every 2 years with supplemental webinars in the interim. On July 30th, 2024, the Bill and Melinda Gates Foundation will host a GVIRF webinar entitled New Combination Vaccines. This webinar will highlight the need for combination vaccines, explore recent innovations that could help surmount some of the formulation and delivery challenges, explore challenges in how to estimate the total vaccine value proposition for future combination vaccines, and consider the benefits from the successful development of new combination vaccines. A link to register for this webinar was provided in NIH's written report. Thank you.
Thank you very much. And last but not least, for the VA, Sophia Califano.
Good morning. Thanks for the opportunity to give an update. VHA submitted detailed written updates, but what we wanted to highlight most was really that progress in the IIS and IZ Gateway work, which Dr. Pam Palperio presented on this morning. VHA is so proud of what has been accomplished by Dr. Palperio's team in collaboration with interagency partners. This significantly improves our vaccine records, and we know that a strong provider recommendation promotes vaccine trust and uptake, and having an accurate vaccine record really facilitates that clear, well-informed, individualized discussion and recommendation for the veterans we care for. So thank you for the partnerships that facilitated that work and for the opportunity to present that work this morning. And nothing further to highlight today. Thanks.
Thank you very much. And this concludes our verbal reports from our liaison and ex officio members. We will now adjourn for lunch. We will be out until 1:15 Eastern Time, at which time we'll return for our last panel towards an updated national strategy, progress, and priorities. Thank you all for joining us for our June NVAC meeting. We now stand adjourned for lunch.
Produced by the U.S. Department of Health and Human Services.